Good morning and thank you for the opportunity to present our project today. I'm Leah and I co-led this project with Dr. Shirley Jonathan, and our project was the Early Years Autism Assessment Toolkit and Pathway, and that was for children referred who were under the ages of 5 years. We want to say a thank you to our wonderful team, to all the professionals involved in carrying out these new assessments, embracing the new changes and adapting their practice. So pre-COVID, most of our assessments for autism were clinic-based on hospital sites. And when the disruption occurred to the services, we had to really adapt our pathway. We usually use the Autism Diagnostic Observation Schedule, the ADOS, but because this isn't standardised with a social partner wearing a mask, we weren't able to use it anymore. So we did some research and we were pleased to find a growing evidence base for ASD assessment, autistic spectrum disorder assessment, and telehealth, which was really promising. So using this research and the new assessments that we devised, we built a new pathway and a new ship to navigate through the choppy waters and the ever-changing waves of the pandemic. So why is it so important that we keep the flow of assessments going for these young children? It's because we know that it's widely evidence-based that children with autism face inequalities. Early intervention is really crucial, and support for these families provides a huge difference. So we want to keep the flow of assessments going so we can offer these early diagnosis so that parents and teachers can support their children and better understand their needs. And this is even more important now with September, with the additional learning needs reform coming in, which will change the way that provision is organised for children and in their education.
So the main aims of our pathway included the fact that we wanted to personalise the diagnostic journey for each child based on their needs. This would fit with prudent healthcare. We know that one shoe does not fit all, so a child's needs would be different depending on their services would depend on their needs. We wanted to devise a prudent pathway which would provide timely, valid and quality assessments. This would increase parent participation and co-production and would move telehealth to the forefront. We wanted to continue the flow of assessments during the pandemic and to gain feedback from parents and use this to inform our future pathway. We wanted to enhance our families' experience of the assessment process, and we were hopeful that we would be able to reduce the number of assessments and thereby support the reduction of wait times from referral to diagnosis.
So the part one of our toolkit was the telehealth element, and this includes the parental interview and a specialist speech and language social communication assessment. There are many benefits to using telehealth for assessment, and the main benefit is that it provided us a window into the child's living room so we could see them in their natural setting with their familiar toys, interacting with their caregiver and their attachment figure, which provided us with such rich information about their needs and also their strengths as well. Because in a clinic setting, it's often artificial and they're interacting with a professional, which is an unfamiliar adult. So we felt that this was a much better representation and more meaningful of their skills. Also, the other benefits are that it reduced travel time to clinic as well, and it was less stressful for parents. So the toolkit includes elements of assessment that are for children pre-verbal, using single words or have lots of language, and it includes observation of parent-child interaction and play, and also coaching elements as well. So the therapist can provide coaching for parents to try things that elicit communication for us to view how they're communicating and how functional that is. The parents are prepped beforehand, so they know what toys to have available based on their child's needs and interest. And some of the examples of the coaching that we might provide is we might coach the parent to offer choices, to use props, blow bubbles, use puppets, and we can also use things directly over the screen that will stimulate the child's interest as well. And we found visual stimulating props much more useful, like this light up windmill that you can see on the page there. So with children with language, they also need additional assessment elements to the children who are pre-verbal. So we would need to obtain a language sample, and we can do that via book sharing and through play, talking about pictures over the screen. We would need to elicit conversation and assess their reciprocal skills. And again, we would use things that they're really motivated by. For example, in this second picture, this is a Minecraft background, and that was used for a child who really liked Minecraft. We would need to probe emotional literacy and social thinking and inferencing, and we would do that through picture sharing with our screen, talking about the pictures and eliciting conversation about what the person in the picture might do or say next, things like that. There's also the option of inviting the parents to share video clips of everyday situations, and we found that this gave us an opportunity to observe the impact of their differences in real life situations. And this was actually based on research through Smith et al. In 2017, who's developed a NODA app for the autism assessment. So we based this element of the assessment on that evidence base.
So the second part of our toolkit includes a new face-to-face assessment called the Brief Observation of Symptoms of Autism. This was developed by a team in UCLA, particularly for use during COVID. The parent would be the social partner administering the assessment and who would be mask-free. The clinician would be observing from a social distance, and this increases the parent co-production. We are engaged in a collaborative project with UCLA, providing data validation so that this tool might be used more efficiently in the future. There are 4 modules to the BOSA, and the higher modules provide more conversational prompts. We developed crib sheets to facilitate providing the interaction or providing the assessment, and coached parents to allow them to be able to do this. So our early years ND team consists of health professionals, so doctors, specialist speech and language therapists, specialist health visitors, and our colleagues in education, so specialist teachers, additional learning needs leads, and also early years specialist teachers. Our pathway demonstrates principles of prudent health care. We do only what is needed, providing a service based on need, thereby reducing variation and increasing co-production with parents, and hopefully reduce the footfall to clinic. So the first step in the pathway would be referral to the early years ND team. The family would then be offered a range of assessments from the toolkit. We would then discuss the evidence based on DSM-5 criteria, and we would then provide feedback to the parent and signpost them to different services, ensuring that each child has a tailor-made support package. We were also able to provide intervention while the child was on the waiting list. So our outcomes between September 2020 and March 21, we were able to achieve diagnostic outcomes for 85 children, 74 of whom fulfilled criteria for the diagnosis of autism. Without these new approaches, all these children would still be on our waiting list. Of the 55 children in this period that received a specialist social communication telehealth assessment, 23 received a diagnosis of autism without needing a further clinic assessment. So that means 42% were able to go direct to a feedback clinic. Some of these required face-to-face assessment because they had not been seen at all because of the virtual nature of our work. For the BOSA clinic, we included 62 patients in the project, and 51 of these were given a diagnosis of autism spectrum disorder. 9 of these either had a language disorder or global developmental delay. Our assessments provided rich information with a high confidence rating, and we reduced duplication.
We asked parents for feedback using digital questionnaires, and we were pleased to find that 93% of parents were strongly agreed that their child's communication and difficulties and their strengths were understood. And all of them, with the exception of one, said that they would recommend the session to those with similar needs. And for the patient experience of the new face-to-face, 95% of parents said they agreed with their child's diagnostic outcome. And we had so much positive feedback about these sessions. And both the feedback from telehealth and face-to-face sessions supports the finding of Resetel in 2013, who found that there was no significant difference in the reliability of diagnostic accuracy and parent satisfaction between face-to-face versus video call. So what's next? We want to continue to improve the family's experience of their diagnostic journey by offering a mixture of both telehealth and face-to-face. And we're going to continue to study the clinical markers to decide which children are likely to only need telehealth sessions and which children will still need face-to-face. And in our experience, this has been the children with sentence level language and also mixed presentation. And this is also congruent with the findings of Gerard in 2018, who found that remote clinicians diagnosed in ASD did not feel capable of ruling in or out autism in 13% of cases. So we also plan to improve the quality of our intervention pre and post diagnosis, starting with developing a new speech and language therapy programme where families are offered intervention as soon as social communication needs are first identified and while they're waiting for assessment. We want to continue to improve their overall journey and put the children and families at the heart of what we do.